If sex after 45 has suddenly started feeling like sandpaper or hidden razor blades, you are not broken. If you find yourself making excuses to go to bed early just to avoid your partner, listen closely. This agonizing pain is absolutely not in your head, and it is not a sudden loss of libido. Furthermore, buying gallons of expensive water-based lubricant will absolutely never fix the biological root cause of this pain. You are dealing with a highly predictable biological tissue change called Genitourinary Syndrome of Menopause, or simply GSM. As systemic estrogen drops during perimenopause, the estrogen receptors located in your vulvovaginal tissue essentially begin to starve. This starvation causes the tissue to thin out, lose vital elasticity, and become highly susceptible to microscopic tearing. Those tiny micro tears are the exact reason you feel that intense burning sensation every time you attempt intimacy. The biggest lie women are told about painful sex in menopause is to just use more lube today. Lubricant is nothing but a temporary band-aid for friction that lasts for maybe 30 minutes at the most. It does absolutely zero to heal the microscopic tears or restore the structural integrity of your vaginal tissue. When intimacy feels like tearing, your body is screaming that the vaginal epithelium has lost its protective collagen. You do not hate your partner, and your romantic life is not permanently over just because you age. You simply need a targeted medical intervention that addresses the severe estrogen deprivation happening at the cellular level. I have seen this exact scenario play out thousands of times, and the biological solution is remarkably straightforward. We just need to stop treating a profound hormonal deficit with slippery liquids and patronizing advice about wine. I am Dr. Lisa Sheld, a board-certified OB-GYN and ANAMS-certified menopause practitioner specializing in female sexual medicine. Over the last 15 years in my specialized menopause clinic, I have treated over 10,000 women personally. These are women between the ages of 40 and 65 who thought their sexual identities were permanently gone. My clinical protocols are strictly anchored in the latest scientific data from the North American Menopause Society guidelines. I also heavily rely on the clinical consensus from the American College of Obstetricians and Gynecologists regarding treatments. We use evidence-based medicine from the International Society for the Study of Women's Sexual Health to guide care. In my practice, we never dismiss painful intercourse as a normal or acceptable part of the aging process. Instead, we treat genitourinary syndrome of menopause with the exact same clinical rigor as we treat cardiovascular disease. Most general practitioners, unfortunately, received less than 2 hours of dedicated menopause training during their entire medical education. This is not their personal fault, but rather a massive systemic failure within our modern medical education system. Menopause medicine is a highly complex specialty that requires rigorous continuing education and specific board certifications to master. Because of this educational gap, the greatest betrayal in modern women's healthcare happens inside the primary care office. A patient finally gathers the immense courage to mention that sex has become agonizingly painful and completely undesirable. Her doctor dismissively tells her to just buy some coconut oil, have a glass of wine, and relax. This lazy advice deeply shames the patient, making her feel like her body is broken and marriage doomed. She leaves the clinic feeling completely isolated, silently enduring the severe physical pain and the crushing emotional guilt. Consider my patient Sarah, a 49-year-old marketing executive, managing a demanding career and 2 teenagers in high school. She came to her family physician complaining of severe vaginal burning, recurrent urinary tract infections, and zero desire. Her doctor told her these symptoms were just normal aging and suggested she try pelvic floor physical therapy. She spent 6 months and thousands of dollars on therapy, but the tearing sensation during intercourse only worsened. Sarah began avoiding her husband completely, faking stomach aches and going to sleep early just to escape intimacy. By the time she finally reached my specialized menopause clinic, her vaginal tissue was severely atrophied and bleeding. She sat in my office crying, terrified that her husband would eventually leave her because she was broken. It took only a brief physical exam to diagnose her with severe GSM, a condition we easily reverse. The tragedy deepens when a woman actually gets the correct prescription for local vaginal estrogen from a provider. She takes her prescription to the pharmacy, hoping to finally find some relief from the daily burning pain. The pharmacist hands her a medication box covered in a terrifying FDA black box warning about strokes and cancer. She reads this insert, panics about the cancer risk, throws the medication in the trash, and continues suffering. I need you to understand that this terrifying class action warning belongs on high-dose systemic estrogen, not local therapies. Local vaginal estrogen stays directly in the vaginal tissue and does not significantly enter your systemic blood circulation. The systemic absorption is literally less than what a premenopausal woman naturally produces on her lowest hormone day. Do not let that outdated pharmacy printout scare you away from the exact biological cure your body needs. We must clearly differentiate between temporary symptom management and actually treating the underlying biological pathology of vaginal tissue. When you apply a water-based lubricant, it simply creates a temporary slip-and-slide effect that reduces friction for hours. It does absolutely nothing to thicken the vaginal epithelium, restore lost collagen, or increase essential blood flow locally. Conversely, local vaginal estrogen actually rebuilds the cellular structure of the tissue from the inside out over weeks. It brings back the protective lactobacilli bacteria that keep your vaginal pH properly acidic and completely infection-free, always. Without this localized estrogen, the tissue remains thin, dry, highly fragile, and incredibly susceptible to painful micro-tears daily. You cannot simply meditate your way out of a severe hormonal deficit, nor can you fix it naturally. Science provides us with a safe, highly effective tool to reverse this damage, and you deserve access today. Many women feel immense guilt when their libido plummets, blaming themselves for not wanting intimacy with their partners. I always tell my patients that it is completely logical to lose your sex drive when intercourse hurts. Pain fundamentally kills libido, and your brain is naturally wired to avoid any activity that causes physical trauma. We cannot even begin to discuss psychological desire or relationship counseling until we first fix the biological damage. Once we restore the vaginal epithelium and eliminate the physical pain, the spontaneous desire for intimacy returns naturally. You must stop accepting this agonizing discomfort as a mandatory punishment for navigating the perimenopausal transition into aging. Your sexual health is a critical component of your overall well-being, and it requires precise, evidence-based medical intervention. We will bypass the lazy medical advice and focus entirely on the clinical strategies that actually rebuild tissue. Today, I will walk you through the exact local vaginal estrogen protocol that we use daily in clinic. I will explain the critical 14-day loading phase that is absolutely necessary to properly saturate starved estrogen receptors. We will discuss the specific maintenance phase using estradiol cream, Vagifem inserts, or the continuous ultra-low-dose E-string. More importantly, I will share the crucial external application technique that almost every doctor completely forgets to mention. You must apply the medication to the vestibule, not just internally, because that is where micro-tears actually happen. If you cannot use estrogen, I will also detail the highly effective vaginal hyaluronic acid suppository alternatives available. Relief from the daily burning and dryness typically begins within just 2 to 4 weeks of starting treatment. You will learn exactly how to safely restore this tissue, eliminate the pain, and finally reclaim your relationship. My very first clinical protocol for painful intercourse and severe vaginal dryness is generic estradiol 0.01% cream. You must rigorously follow the specific clinical loading phase to properly saturate your starving vaginal estrogen receptors. Insert 1/2 to 1 full gram using the provided vaginal applicator nightly for exactly 14 days. After these initial 2 weeks, you will seamlessly transition directly into the standard clinical maintenance phase protocol. This maintenance phase simply requires using the exact same estrogen cream just 2 times per week overnight. Applying the medication right before bedtime ensures maximum tissue absorption while you rest peacefully through the night. This specific localized treatment directly targets the fragile vaginal tissue without heavily impacting your systemic hormone levels. However, simply inserting the cream internally is not enough to completely resolve your painful sexual intercourse symptoms. Here is the crucial application technique that almost every single medical provider completely forgets to mention today. You must never restrict this vital estrogen cream solely to the internal walls of the vaginal canal. Take a small, pea-sized amount of the medication directly onto your clean fingertip before every single application. Gently rub this cream directly onto the external vulva and the vestibule surrounding the actual vaginal opening. The vestibule is precisely where those excruciatingly painful microscopic tears actually occur during any physical intimate contact. If you ignore this external tissue, intercourse will remain incredibly painful despite successfully treating the internal canal. Restoring the external epithelial barrier is absolutely mandatory for achieving completely pain-free and highly comfortable sexual intimacy. This simple clinical adjustment often provides the exact breakthrough my frustrated patients have desperately sought for years. Why does this targeted local estrogen succeed so brilliantly when expensive commercial water-based lubricants consistently fail you? As your systemic estrogen drops during menopause, the localized hormone receptors in your vulvovaginal tissue literally starve. This severe hormonal starvation causes the delicate tissue to thin significantly and lose its vital structural elasticity. The vaginal environment simultaneously shifts toward a highly hostile, alkaline pH that practically invites dangerous recurrent infections. Local vaginal estrogen actively reverses this damage by biologically rebuilding the fragile tissue from the inside out. It directly restores lost cellular collagen, drastically increases local blood flow, and effectively thickens the vaginal epithelium. Furthermore, it brings back the protective lactobacilli bacteria that naturally keep your vaginal pH environment perfectly acidic. Lubricant is merely a temporary slip and slide, whereas local vaginal estrogen actually reconstructs your essential biological cellular architecture. This protocol beautifully fits any perimenopausal or postmenopausal woman experiencing painful intercourse, severe dryness, or recurrent infections. However, you must avoid this specific treatment if you currently experience any undiagnosed abnormal vaginal bleeding episodes. If you have a history of estrogen-dependent breast cancer, local therapy requires careful shared clinical decision-making processes. The American College of Obstetricians and Gynecologists states local vaginal estrogen is generally safe for these survivors. You must always coordinate the specific prescription closely with your managing oncology specialist to ensure complete safety. Expect noticeable relief from daily burning and uncomfortable vaginal dryness within just 2 to 4 short weeks. Wait 8 to 12 full weeks for complete tissue restoration before attempting deep sexual intercourse ever again. If you find creams too messy, another highly effective clinical protocol perfectly restores this exact same tissue. The second highly effective protocol utilizes the Vagifem or Uvifem 10 microgram localized vaginal estrogen tiny tablet insert. This tiny insert provides an incredibly precise hormone dose without the messy discharge often associated with creams. You must follow the exact same clinical timeline to ensure the starved epithelial tissue heals completely correctly. Insert one single tablet high into the vaginal canal nightly for the crucial 14-day initial loading phase. Afterward, you simply drop the frequency down to twice weekly to properly maintain the beautifully restored tissue. You may still need a tiny bit of estrogen cream externally for the highly delicate vulvar tissue. Before I explain the continuous 90-day estrogen ring option, please subscribe to this medical channel right now. Subscribing ensures you never miss these critical, science-backed menopause protocols that actually heal your specific biological symptoms. The E-string is a brilliant clinical alternative that provides continuous healing without annoying weekly maintenance schedule reminders. This flexible, silastic ring sits comfortably high inside the vaginal canal and stays securely in place always. It releases an ultra-low, continuous dose of exactly 7.5 micrograms of localized estradiol daily. You simply set a calendar reminder on your smartphone to swap the healing ring every 3 months. If you absolutely cannot use any form of local estrogen, you still have highly effective alternative options. You must use a targeted vaginal hyaluronic acid suppository, like Reverie, every 2 to 3 full days. Unlike basic lubricants that just coat the surface temporarily, hyaluronic acid draws deep moisture into vaginal cells. This intensive cellular hydration effectively promotes natural healing and significantly reduces painful friction during any intimate moments. We must aggressively address the terrifying FDA black box warning that accompanies your new local vaginal estrogen prescription. When you pick up your medication, the pharmacy insert loudly screams about heart attacks, strokes, and cancer. I need you to understand that this class action warning strictly belongs on high-dose systemic estrogen replacement therapies. It absolutely does not apply to the extremely low medication doses found in localized vaginal estrogen products. Local vaginal estrogen stays directly in the vaginal tissue to effectively heal the damaged cellular architecture locally. The systemic absorption into your bloodstream is incredibly negligible and clinically insignificant for your overall physical health. In fact, it is less than what a premenopausal woman naturally produces on her absolute lowest day. Do not let the pharmacist's outdated, automated warning printout scare you away from healing your physical body. The ultimate biological truth is that genitourinary syndrome of menopause strictly remains a chronic, progressive physical condition. However, it is entirely and completely reversible with these exact local vaginal estrogen protocols I just shared. You absolutely do not have to suffer in silence while your precious, intimate relationships slowly deteriorate needlessly. You do not secretly hate your partner, and your physical body is absolutely not permanently closing down. By simply replenishing the localized hormones your starved tissue desperately needs, you actively reverse the painful damage. I see patients who thought their sexual identity was gone completely return to their incredibly vibrant selves. This profound clinical transformation is not magic. It is simply replacing the exact biological hormones you lost. You can fully restore your physical comfort and safely reclaim the beautiful, intimate, romantic life you deserve. I want to hear from you directly, right now, in the comment section below this medical video. Tell me your age, your top 3 menopause symptoms, and if your doctor ran comprehensive hormone panels. Make sure to check the description below to immediately download my free Menopause Symptom Tracker clinical document today. You will also find the complete hormone test checklist PDF, so you know exactly what to ask. Use the provided link to find a NAMS certified medical practitioner in your specific area who actually listens. You deserve a dedicated medical provider who understands the profound biological reality of female sexual health medicine. In our next video, we are tackling the exact clinical difference between local and systemic hormone therapy. Hit the notification bell so you know exactly what happens when you finally need systemic, full-body HRT.